Okay. So yes. Okay, dear. I was just checking. So, am I audible? Am I audible? Please let me just know by the students. I'm audible. Okay, I'm audible. So yes, we can start the session. So today I'm going to discuss all the anatomy questions which has been asked for the FMG exam, and most of the question was done already. The topic is also repeated, and the anatomy questions were very easy. बहुत easy था बच्चे. Okay. So let me start with the first without wasting much of time. I think I have gathered 18 MCQs, so I'm going to discuss all of it. A patient underwent a parodectomy. Post-operatively, he complains of excessive sweating and redness over the parotid gland periauricular region, especially during the meals. What is most likely the diagnosis? So the options are Frey syndrome, Horner syndrome, crocodile tear syndrome, first bite syndrome. So any idea, my dear students? Any idea? Any idea? What is will be the right answer here? So the right answer is Frey syndrome. Why? Because the key point which is mentioned, so let me highlight the key points. It is a case of parodectomy, parotid gland removal, and after the operation of removal of parotid gland, excessive sweating is there. The patient is having excessive sweating, redness over the parotid or the periauricular region, and so the nerve being injured will be auriculotemporal nerve, and we know that auriculotemporal nerve is having the parasympathetic fibers, also component of sympathetic component. And basically, what happens if it is injured? Auriculotemporal nerve syndrome is also called as Frey syndrome. When it is injured, when the regeneration of nerve takes place, it grows with the great auricular nerve, and that is the reason when the patient. So you can see here, this is a case of Frey syndrome, which is there will be redness and sweating over the anterior aspect of the ear. So gustatory sweating, the patient will experience gustatory sweating, flushing of the cheek area after eating the food, and it is a common complication which is seen in parotid gland surgery. So you can see the arrow marked area. I'm just enlarging it, which is showing the parotid gland region has been involved. The skin over this area has been involved because of regeneration of auriculotemporal in the great auricular nerve. So the other option is not correct. Like, why Horner syndrome is not correct? We know when the patient will have Horner syndrome, the sympathetic fibers are involved, and when the sympathetic fibers are involved, what will happen? Sympathetic fibers are involved. That means three clinical, actually 4-5 clinical syndromes are there. Most commonly, three features has been seen. One is drooping of upper eyelid, that is ptosis. Other is constriction of pupil, and the other is anhidrosis, absence of sweating. The patient will have absence of sweating, the patient will have constriction of pupil, the patient will have drooping of upper eyelid. So this is due to involvement of sympathetic fibers. So definitely this is not the right answer. If I am talking about crocodile tear syndrome is also called as Bogart syndrome, and this is a case of gustatory lacrimation. So patient will shed tears while eating or smelling food. Okay, so the reason of this crocodile tear syndrome is aberrant regeneration of facial nerve. Aberrant regeneration of facial nerve, that is cranial nerve 7, after the injury, causing autonomic fibers to get misdirected to lacrimal gland instead of salivary gland. So obviously this was not the clinical features mentioned. This was not the clinical features mentioned, so it is also not the right answer. What about the last option which was given, first bite syndrome? That means actually the reason is damage of sympathetic fibers which is supplying the parotid gland. And when the nerve is damaged, actually we know that in the parotid gland there is myoepithelial cells, which is a contractile cell which has got a function of contraction and releasing the secretion. So hypersensitivity to the parasympathetic nerve stimulation happens. The hypersensitivity will lead to exaggerated painful contraction with the first bite. Why? Because parasympathetic nerve are unopposed by the damaged sympathetic fibers, and this is the case of first bite syndrome. So this was also not the key features and clinical history provided in the MCQ. So all these options are wrong and the right answer is Fraze syndrome, auriculotemporal nerve syndrome. Is it okay, everyone? So we have done with the first MCQ. Now let's move, and I think most of you must have given the right answer. Let's move on to the second MCQ. A patient presents to the OPD with a complaint of ophthalmoplegia and ptosis. Okay. On examination, a diagnosis of superior orbital fissure syndrome is confirmed. Superior orbital fissure syndrome. So actually, superior orbital fissure syndrome, if I am talking about this syndrome, so the nerves traversing from superior orbital fissure has been involved, and the important nerves which is traversing from superior orbital fissure, it is divided into three parts by the ring origin of the recti muscle, four recti muscle. What is it called as? It is called as annulus of Jit. What is it called as? That is called as annulus of Jit. So that will divide the superior orbital fissure into three parts. And we have got LFT, lacrimal frontal trochlear, and superior ophthalmic vein passing from the lateral or the upper part. We have got the oculomotor nerve, that is the third cranial nerve, upper lower division, the nasociliary nerve, the abducens nerve, and also from the lower medial aspect we have got the inferior ophthalmic vein. Now here the wrong options are, for example, here in two option V2 is mentioned. What do you mean by V2? That is maxillary. When this V2 means maxillary division of trigeminal nerve. Now, if I talk about maxillary division of trigeminal nerve, it is passing through foramen rotundum. So it is passing through foramen rotundum. It is not passing the superior orbital fissure. So this is wrong. This is a wrong option. Here, second optic nerve is also wrong. Why? Because second optic nerve is passing through optic canal and not through superior orbital fissure. So the correct answer is A, which is showing the nerves traversing through superior orbital fissure is third cranial nerve, fourth cranial nerve, sixth cranial nerve, and V1, that is ophthalmic division of trigeminal nerve, which further branches of the ophthalmic division of trigeminal nerve passes through the superior orbital fissure. Now here we can, I want you to show this image in which you can see the superior, you can see the anterior view of the orbit. Here you can see, let me just enlarge this. Yeah. So here you can see this retorsive fissure is superior orbital fissure and this is optic canal. So we are concerned with superior orbital fissure, and we can see from anterior view of the orbit the superior orbital fissure, and when you see the superior orbital fissure, you can also appreciate that this is the tendinous ring which is giving origin to the four recti muscle, and this is called tendinous ring of annulus, and it will divide the superior orbital fissure into the upper, into the lower, and the middle part. So the nerves which is traversing from the upper part will be L, F, T, and superior ophthalmic vein. L for lacrimal, F for frontal trochlear, and in the middle part lower and upper division of the oculomotor nerve, nasociliary nerve, and abducens nerve. From the lower medial part, the inferior ophthalmic vein is traversing. So we have described and I have told you about all the nerves which is passing through superior orbital fissure, and it is quite clear to us that the maxillary nerve is not passing through superior orbital fissure, and here you can see this is the optic canal, and through the optic canal we can see, if I am talking about optic canal, if I am just talking about optic canal, two structures passing O2. What is ophthalmic artery and optic nerve? So definitely the right answer here will be third cranial nerve, fourth cranial nerve traversing, also the ophthalmic nerve branches traversing, and the abducens nerve traversing. So we will have the correct answer here. We will have the correct answer here as the option A. Is it okay? Let's move on to the next MCQ. Third MCQ. So this is also very easy. If you remember, I have described the posterior triangle of the neck. Identify the nerve indicated and the clinical case in the given image. So we can see the lateral side of the neck, that is posterior triangle of the neck, and arrow is pointed. So the blue color arrow which is pointed here is showing the posterior triangle of the neck, And to the border of sternocleidomastoid muscle, we have got the cervical point from which four cutaneous nerves are traversing in four directions. So actually the nerve which has been pointed in the posterior triangle here, which is actually going towards the ear area, actually greater auricular nerve is the right answer. Greater auricular nerve gives anterior and posterior division, which will go anterior and posterior direction towards the ear. So here you can see, I just want everybody to just see this image where I want to highlight the muscle. So this is sternocleidomastoid muscle and that of trapezius muscle. Okay, and this muscle is trapezius muscle. So these two muscles are forming the boundary of which area? The green color area. What is this area? This is the posterior triangle of the neck. Okay, this is the posterior triangle of the neck. Now let's highlight the nerve. So here we can see this is the great auricular nerve having anterior and posterior division, which is giving cutaneous sensation in the area shown, that is in the area anterior to ear and this posterior to the ear in the region of auricle. And the other nerves which are also shown, one of the nerve going transversely, that is transverse cutaneous nerve, one going lower down, that will be supraclavicular nerve, and one going towards the occipital bone is lesser occipital nerve. So that means this is the region of posterior triangle of the neck where we can see four cutaneous nerves, which are the branch of cervical plexus, which is fruiting like a flower in four directions. So exactly the area which has been shown and the branches which is traversing upward is great auricular nerve. I want everybody to pay attention to the great auricular nerve, a sensory branch from the cervical plexus. What is the root value? C2 and C3. It's also important for you to know the distribution of great auricular nerve. So it is giving innervation to the skin of parotid gland, skin over the mastoid process, also the skin on the external ear auricle, posterior branch innervate auricle part, not the upper part, lobule and lower part of concha. In addition, great auricular nerve is also giving innervation to parotid gland and its fascia. So it's very important for you to identify the nerve and know the distribution of great auricular nerve. After this explanation, it is quite clear that the right answer for this clinical image-based question is, or if no clinical note was there, just an image, the right answer will be great auricular nerve. Okay, dear. Let's move on to the next MCQ. Identify the case. Okay, so you have to identify this case. Identify the case. So whether it is a case of extradural hematoma, epidural hematoma, subdural hematoma, subarachnoid hemorrhage, or intracranial hemorrhage. So actually, okay, this is a case of subarachnoid hemorrhage. Why? Because we can see there is hemorrhage involving the part of in the basal area, in the circle of Willis area, which is a common site for subarachnoid hemorrhage, to the rupture of aneurysm in case of berry-aneurysm, in case of hypertensive elderly people, and it is going laterally in the sulci and gyri of the brain. So subarachnoid hemorrhage is right. So basically, the CT scan of the brain, which has been shown in the MCQ, is showing subarachnoid hemorrhage, where the hemorrhage is shown in the middle of the center, marked by an arrow, and stretching of this hemorrhage is going into the sulci on either side. So subarachnoid hemorrhage occur as a result of head injury, and it is due to the rupture of cerebral aneurysm. Actually, aneurysms are quite common. If I talk about aneurysm, okay, yeah. Just okay, everyone, can you hear it? Is my voice okay? Please check. My voice is okay? Let me just check. Okay, let me just okay. Is the voice okay? Okay, let me just check. Okay, so this is the case of cerebral aneurysm. Okay, and we can also see this is a case of cerebral aneurysm. And let me just this yeah, this is a case of cerebral aneurysm, and you can see the blood is going into the adjoining area of the sulci. So basically, it is not a case of epidural extradural hemorrhages because it is seen. The bleeding, as you can see, is from the area of mainly in the central area. It must be bleeding. Aneurysm common site is very aneurysm in the area of circumflex, and the common artery being involved is anterior communicating artery or the junction of anterior communicating anterior cerebral artery. Okay. Okay. So let's now move on to the next MCQ. That is MCQ number 5. In nerve conduction. So a nerve conduction, if I talk about a nerve conduction study is being performed as shown in the image. So as shown in the image, electrodes are placed near the wrist and stimulation is being given to assess the motor and sensory function. What is the nerve most likely involved or monitored in this setup? The nerve is radial nerve, median nerve, ulnar or axillary nerve. So I just want to enlarge this image. So when I am enlarging this image, you can very nicely or clearly you can see the medial side. This is the medial side of the hand, and this is the medial aspect close to the wrist. The electrode is placed. So the nerve being tested is ulnar nerve. So if I talk about the nerve being tested in this condition is ulnar nerve. We know that ulnar nerve and ulnar artery will pass superficial to flexor retinaculum. Medial nerve passes deep to flexor retinaculum. The key point which is important here is to know the location of electrodes, which is on the medial side. So definitely ulnar nerve is the right answer. Now here, before proceeding to the next MCQ, I want you to understand about the course of ulnar nerve when it is traversing from forearm and passing to the wrist and reaching the hand. So exactly you can see ulnar nerve. If I am talking about the ulnar nerve and ulnar artery will pass superficial to flexor retinaculum. So basically it is passing superficial to flexor retinaculum. So this is passing superficial to flexor retinaculum, and after that it travels in the hypothenar region muscles or hypothenar eminences region muscle, and it is distributed. It is giving innervation to the hypothenar eminences muscle. Which muscle is this? The muscle is abductor digiti minimi, flexor digiti minimi brevis, opponens digiti minimi brevis. So actually when the ulnar nerve and ulnar artery passes superficial to flexor retinaculum into the hand medially, it is covered by a superficial slip of flexor retinaculum that is called as volar carpal ligament. And the space below volar carpal ligament bounded by hook of Hammett and pisiform on either side, this space is called as Guyon's canal. So it is the area of Guyon's canal where the ulnar nerve gets compressed. So that was similar to the location of electrode. So this is the right answer. Here I want you to show ulnar nerve and its cutaneous distribution. So we can see the superficial branches and its cutaneous distribution in the medial 1.5 of the hand. I also want everybody to appreciate, the cutaneous distribution of the ulnar nerve and median nerve in the hand. So I am showing you this image where you can appreciate the palmar and the dorsal aspect of the hand, and you can see the ulnar nerve distribution on the medial side And also on, so what we can say, the palmar medial aspect of the hand and 1.5 of the finger, the dorsal medial side of the hand and 1.5 of the fingers is getting innervation via ulnar. If you will see this image, we have got the palmar aspect, and on the palmar aspect laterally, on the palmar aspect, if I am talking about lateral aspect, lateral 3.5 of the palm and the fingers are getting innervation from medial nerve and the nail burrs, and also the nail burrs, 3.5 of the nail burrs on the dorsum aspect. The rest whole area is having distribution via radial nerve. So it is quite clear the correct answer will be ulnar nerve because of the placement of electrode which was shown in the image. Okay, now let's move on to the next MCQ. So this is very easy MCQ, and I think most of you should have given this right answer. Most of you must have given this right answer. Root value affected in the given image. Which root value is affected in the given image? Any of the students, if they are remembering the question which is asked in FMG or the literature or the clinical aspect or anything other option, they can just share with me. Okay, so which root value is affected? So this is a image which has been shown of the baby, I think. So here what is that you can see the arm is hanging by the side of the body. So here the position of arm is adducted, medially rotated, and forearm is extended and pronated. Okay, is it okay now? Is it okay? Yeah, I think now it is Tantu. Now it is okay. So basically, the nerve root affected is C5 and C6. If I talk about nerve root being affected, it is C5 and C6, and this is a case of upper trunk brachial flex injury. This is a case of upper trunk brachial flex injury. This is a case of upper trunk brachial flex injury. Here, the arm hangs by the side. So the arm is medially rotated and adducted. And the forearm is, the position of forearm is, it is extended. The forearm is extended and pronated. The forearm. Okay. So this is the position of arm and this is the position of forearm which has been shown in this image, and this is the case of upper trunk brachial flex injury. And what is the root values of the nerve being compressed? It is C5 and C6. So basically we can see two cases are there. One is Orb's brachial flex injury, other is Klumpke's paralysis. In Orb's brachial flex injury, C5, C6 nerve roots are affected. In lower trunk brachial flex injury, Klumpke's paralysis, C8 and T1 nerve roots are affected. And the abnormality, as I have already told you about the abnormality, that is Orb's Duchenne paralysis, the arm hangs by the side and it is adducted and it is medially rotated and forearm is pronated, as you can see here, and extended. It feels like someone is asking money from behind. So it is also called as policeman tip deformity or waiter tip deformity. The other image which you are seeing is of Klumpke's palsy, that is lower trunk brachial flex injury. In case of lower trunk brachial flex injury, C8 and T1 nerve root is affected, and in hand we can see the metacarpophalangeal joint is extended and the interphalangeal joint is flexed. Actually, the patient will have, or the baby will have, medial claw hand. So medial claw hand was not presented. So definitely the abnormality which was shown in the image was of upper trunk brachial flex injury. So the right answer is upper trunk brachial flex injury, and the nerve root being involved is C5 and C6. Okay. Okay. Done. So now I am going to discuss the next sentence. In between, I have checked the voice. Okay. So okay. Thank to Abhishek. Everyone fine with the noise, with the voice. Let's move on to the next MCQ. So question number 7. Question number 7. A patient presents with a history of long bone fracture. Okay. The fracture of either long bone fracture, that is the fracture of femur or humerus. A few hours later, he developed breathlessness, tachypnea and confusion. What is most likely the diagnosis of the case? whether it is a case of fat imbalance, whether it is a case of pulmonary imbalance, whether it is a case of tension pneumothorax, whether it is a case of myocardial infarction. So actually in this case, actually it can't be pulmonary embolus because the long bone fracture and the clinical syndromes and is same as the fat imbalance condition. Tension pneumonia, no history of lung injury or any rib fracture has been given. Myocardial infarction, also pain should be in the chest, radiating to the left side of the arm and the tip of shoulder. So basically such kind of, yes, fat imbalance. So yes, Mani Dheeraj has given a right answer. Yes, Mani, you are absolutely right. Yes, Mani, you are absolutely right. The right answer here is fat imbalance. Okay, so this was the question of anatomy. Also, I think it must be explained in orthopedic question. So many of the anatomy question is integrated with the other clinical subjects. Okay, so basically, most likely the diagnosis of the patient who presents with a history of long bone fracture, whether it is femur or humerus, develops breathlessness, tachypnea, confusion hours later, and sometimes the patient can also have confusion and petechial rashes. And the diagnosis of case is fat imbalance syndrome. I think most of you must have marked this right. So I think most of you must have marked this right. Okay. So most of you must have marked this right. Is it okay? Mani Dheeraj, am I audible? So I will just use this. Okay. Voice is okay, dear? I am placing the mic very close to my mouth. Okay. Now, in the given image, which vein is mainly affected? In the given image, which vein is mainly affected? Okay. So this image, so this is the image which you have to have been shared with you, and you can see here. This is the image of uh, varicose vein. Okay, you can see dilatation of the vein is there, and we know that varicose vein dilatation occurs due to the incompetency of valve. Mani, is it okay? Mani Dheeraj, is it okay? So here in the patient there is dilatation of veins due to incompetency of valves. So the right answer, as you can see, the foot which has been shown is from the area of great toe. So we can see great toe has been shown. That means it is which side of the foot? Medial side of the foot. And great saphenous vein arises, is formed from the medial aspect of the foot by joining medial marginal vein with the medial end of dorsal venous arch. So great saphenous vein is the right answer. Yes, Mani Dheeraj, you are right. Okay. Yes, Mani Dheeraj, you are right. I am asking whether my voice is okay now. I am audible? Okay. So here again you can see this is the medial marginal vein of the foot. This is the medial end of dorsal venous arch. This will lead to the formation of great saphenous vein, which ultimately drains into femoral vein. So formative vein, the formative vein of great saphenous vein is, it is formed by joining medial marginal vein with that of medial end of dorsal venous arch. Medial end of dorsal venous arch. Okay, fluctuation. Okay, I think now it is okay. So this is the great saphenous vein formation, which is from the joining of medial marginal vein and the medial end of dorsal venous arch. Okay. Now identify the marked bone. You have to identify the marked bone in the image provided. So here you can see this is the navicular bone. No, you have to identify. I already told you the answer. This is N for navicular. Actually, one of the image of the foot has been shown, and there you have to identify which bone is this, whether it is cuboid, intermediate cuneiform, lateral cuneiform, cuboid, navicular. So the right answer will be navicular bone. I will show you the tarsal bone. There are 7 tarsal bone. There is calcaneum, there is cuboid, there talus, navicular, there is the intermediate, medial and lateral cuneiform. So it's very important. Okay. So let's do this. So am I audible now? Am I audible now? I will. Am I audible now? So I'm audible now. I just, yeah. So I'm not taking this mic. So I'm just removing this mic. Is it okay? I'm removing the mic, and I think without mic it is much better. Yeah. So I'm audible. Yeah. I just checked. It's okay. Okay. Um. No, now it is okay. I can hear in my mobile it is okay. I heard my voice in my mobile it is okay. So, Mani Dheeraj, it's okay now. Now you can see the tarsal bones. You can see the lateral. You can see the lateral view, and you can see the view from the superior aspect. So we can see the talus bone. We can see the calcaneum cuboid. This is the bone which has been asked, which is the navicular bone. Okay. This is, and we can see the three cuneiforms, intermediate, lateral, and medial cuneiforms also. So we can see the three cuneiforms, a total of 7 tarsal bones. Total of 7 tarsal bones. And here one more image is there which will help you to understand the bones. So here this is the talus bone, this is the calcaneum bone, heel bone. This is the navicular which has been asked. This is the lateral bone, that is cuboid, and these are the three cuneiforms. These are the three cuneiforms. So total 7 tarsal bone. It's very important that you should identify all the tarsal bones. Now moving to the next one. Now moving to the next MCQ. Question number 10. Which nerve is injured in the image? Okay, so actually for this question there are two questions which I have found. Few students were telling that it was a radiological image based question, and few students were telling no, it was like a clinical photograph was given and then you have to identify. Okay, so arrow mark is there. Can you tell me which nerve is injured in the given image? Which nerve is injured in the given image? Okay, you just check, Mani. You just check yours. It's common peroneal nerve is right, because I can check in my mobile. It is perfectly all right. It is perfectly all right. Okay, you just check, Mani. You just check yours. See here, it is a perfectly all right. So no problem in my mobile. So there must be some problem. You just check your volume of the gadget which you are using. Okay, because I'm just checking in the mobile right itself, and it is completely okay. So common peroneal nerve. Okay. Yeah. Okay. Okay. So it is okay now. Now this is the common peroneal nerve. This is the common peroneal nerve. And this was an another image. This was an another image where you have to identify the injury. So here you can see foot drop. The patient is having foot drop. As you can see, the patient is having foot drop. So the right answer will be common peroneal nerve. The right answer is common peroneal nerve. Okay. So either it was like this, when a radiological image must have been given, or it was like this when a patient photo has been given. Okay, so here common peroneal nerve is the right answer. Now if I talk about common peroneal nerve, yeah, it's okay. A is right answer, dear. Common peroneal nerve winds around the neck of fibula, and after that it divides into two nerves, that is superficial and deep peroneal nerve. So here you can see this is the neck of fibula, where the common peroneal nerve winds and it gives two branches, superficial and deep peroneal nerve. So when common peroneal nerve is injured, what will happen? Both deep peroneal nerve and superficial peroneal nerves are injured. So that means all the muscles of the deep peroneal of anterior compartment of leg is paralyzed, and all the muscle of lateral compartment of leg is also paralyzed. Okay, all the nerves of the muscles of lateral compartment and all the muscles of anterior compartment of the leg is paralyzed. Okay, so here you can see uh, uh, that if I talk about the muscles of lateral compartment of the leg, it is peroneus longus and it is peroneus brevis. That means everters are paralyzed. When I talk about deep peroneal nerve, it is giving innervation to the muscles of anterior leg, that is tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. All are paralyzed. So we know common peroneal nerve having formed by dorsal division, ventral rami of L4, L5, S1, S2. Okay. And this common peroneal nerve divides into two nerves. One is deep peroneal nerve and the other is superficial peroneal nerve. Superficial peroneal nerve is the nerve of lateral leg compartment. They are everters of the foot. So everters of the foot are paralyzed. That means peroneus longus and peroneus brevis are paralyzed. Deep peroneal nerve is supplying which compartment of the leg? Anterior compartment of leg. Anterior compartment of leg. That means it is paralyzing the external hallucis longus, tibialis anterior, extensor digitorum longus, and peroneus tertius. They are all dorsiflexors of the foot. So that means the patient will have foot drop. So the patient will have foot drop. Okay. Okay, dear. So I think this must be marked right by all of you. You must have marked right. So I think most of you must have marked this right. Okay. Now let's talk about question number 11. So that means in this case, foot drop. So the patient is having foot drop. Patient is having foot drop. That means common peroneal nerve is injured. Common peroneal nerve injury. Now, next, at the level of T4. So this is very easy. This is very easy, and I think all of you must have marked it right. At the level of T4, which of the following structures produce physiological constriction of esophagus? So basically, this I have explained so many times, in which I have explained the esophageal constriction. So normally esophagus is constricted at 4 levels. The uppermost constriction is at the level of cricopharyngeus. Basically, what is the extent of esophagus? It is extending from C6 to that of T11. Okay, so basically the first constriction is at the level of C6, second is at the level of arch of aorta corresponding to T4, then is the left principal bronchus corresponding to T5 and T6, diaphragm at T10, and cricopharyngeus junction at C6. So the right answer, that is constriction at the level of T4, arch of aorta, is the right answer. B. Yes, Mani Dheeraj, absolutely right. Absolutely right, dear Mani Dheeraj. So you can see the first constriction is at the pharyngoesophageal junction. Pharyngoesophageal junction corresponding to the level of C6. Second is arch of aorta corresponding to the level of T4. Third is the principal bronchus crossing, and the fourth is diaphragmatic opening of the esophagus. Now, it's also very important for you to know the constriction distance from the central incisor teeth of upper central incisor teeth. So if you measure the distance from the upper central incisor teeth, that is, if we measure cricopharyngeus distance, it is C6 and it is approximately 15 to 16 centimeters. If I talk about arch of aorta, it is T4, approximately 25 centimeters from upper central incisor teeth. Left principal bronchus constriction is at the level of T5 and T6 and it is approximately 27.5 or 28 centimeters. Esophageal hiatus of diaphragm at the level of T10, approximately 37.5 to 40 centimeters from the upper central incisor teeth. Okay, dear. Now let's come to the question number 12. Question number 12. So here there was an image. This must be also solved in the orthopedics. As I told you, many of the question of abdomen and pelvis was integrated with surgery and gynae and obs. And this is a case which you can tell this is a question of orthopedics, or you can tell this is a question of anatomy. So I think I have explained this many times. Here you can know the procedure which is done here, and it is an anterior drawer test which is done for testing anterior cruciate ligament injury. ACL, yes, Mani Dheeraj, absolutely great, Mani. So I think Mani has given all right answers. So Mani, have you solved all anatomy question? Mani to pakka anatomy ke sare question sahi mark karke aaya. Very good. So yes, so excessive anterior translation is seen, then it is in anterior drawer test, then it is the anterior cruciate ligament injury. Ortho correlation, madam. Okay. The anterior drawer test is a physical examination which is done to see the integrity of ACL of the knee joint, anterior cruciate ligament. A healthcare provider will be applying an anterior or the forward force to the tibia, and the knee bending is 90 degree. Excessive forward translation. If there is an excessive forward translation of the tibia in relation to the femur, this suggests that this is a case of ACL tear, anterior cruciate ligament tear. So this was the image provided. The right answer is ACL tear. And what is the name of the test? Anterior drawer test. So this is anterior drawer test. And I would also like to tell you the modification and of this more sensitive test, that is Lachman test interpretation. If more forward translation of tibia, then it is ACL injury. If there is no forward translation, then it is ACL intact. The Lachman test is a physical test for assessing the ACL injury. In this, the bending of knee is not 90 degrees, it is just 30 degrees, as you can say, and is more reliable and sensitive test for detecting the ACL injury. It involves pulling the tibia forward while stabilizing the femur, and if the result is positive, there is more translation of tibia forward, and this will be positive in case of ACL injury. Okay, this will be positive in case of ACL injuries. Now, next question. A person had got loss of sensation on the lateral half of finger. Which nerve? So it is correlated with that ulnar nerve injury wala question. So मैंने already आपको hand की cutaneous distribution explain की है, palmar and dorsal aspect. So you can tell me the right answer. यहाँ पे जो sensation lost हुआ है dorsum of the hand, it is on the lateral 3.5 of the digits, lateral side on the palm, and nail buds may be on the dorsal aspect. So can you tell me the right answer? This is showing you the compression of nerve in a space. Which nerve is that? Mani, Abhishek? The right answer is median nerve. So I have explained many of times in the brachial plex nerves के explanation में मैंने median nerve, radial nerve, ulnar nerve बहुत डिटेल में पढ़ाया है. वहां पे हमने median nerve carpal tunnel syndrome. So mainly the injury of median nerve happens in the carpal tunnel, that is causing carpal tunnel syndrome. Not B, Mani, it will be median nerve. So here you can see this is a section. So let me just show you the fibrous. So this is the transverse carpal ligament, which is also called as this green color I am using. This is transverse carpal ligament, which is also called as flexor retinaculum. Below this, one yellow color nerve which you can see is the median nerve. So median nerve passes beneath the flexor retinaculum. So the space which is lying beneath flexor retinaculum is osseo tunnel, which is carpal tunnel. So median nerve is compressed in case of diabetes mellitus, hypothyroidism, gigantism, cretinism, pregnancy, rheumatoid arthritis, and the compression of nerve will cause carpal tunnel syndrome. So we have discussed so many times. So the right answer here is median nerve. So one of the question was the nerve located in piriform fossa. Okay, can you remember the whole line? Yes, screwdriver injury. So they have told you about sensation lost on lateral side, then median nerve will be the right answer. Okay, Mani. So you can exactly, if you remember the words or correlate with the clinical aspect, you can send me few words. I will come to the right one. But if lateral aspect is involved, lateral aspect of the hand sensation gone, and nail bursts on the lateral 3.5, then the median nerve is the right answer. Okay, Mani Dheeraj. Now, which nerve is injured in piriform fossa? Any idea? The nerve residing in piriform fossa is the, which nerve resides in piriform fossa? Internal laryngeal nerve. So actually, I didn't find the clinical note for this MCQ. So I have framed one clinical question for this. So I have framed, see here, a 60-year-old man with a swelling in his neck. A biopsy shows a benign tumor in the piriform recesses of the larynx. Mucosa of the piriform recesses must be anesthetized during removal of the tumor. Which nerve supplies general sensation to the mucous membrane of laryngeal vestibule and the piriform recesses? So this was a clinical question which I have modified. Okay, if the space is pointed, that will be piriform sinus. Okay, the nerve is internal laryngeal nerve, and agar space was, can you see this? So this is the piriform recesses. So this will be the laryngeal inlet. What is this? This is laryngeal inlet, and the area lateral to laryngeal inlet, this space is piriform sinus, and I will also tell you about the boundaries. And the nerve which is residing here is internal laryngeal nerve. Internal laryngeal nerve. Yes. Okay. So here you should also know about the boundaries. So this is the laryngeal inlet, and this spaces which you are seeing is the piriform sinus, lateral medial wall. So medially, the piriform sinus or piriform space or piriform fossa is having aryepiglottic fold, also the arytenoid and cricoid cartilage. Laterally, it is having thyroid cartilage and thyrohyoid membrane. Thyroid membrane is pierced by internal laryngeal nerve. Superiorly, there is lateral glossoepiglottic fold, and inferiorly, it will communicate with esophagus. So the nerve being injured in this region will be internal laryngeal nerve, and if the space is pointed, it will be piriform sinus. Now, singer cannot raise. So this is a very easy question, and so many times I have explained about thyroidectomy. In previous question, nerve is not asked. Madam, in median nerve question, I am talking about. Okay. Okay, no worries, Mani Dheeraj. This is also a recall which we have gathered from the students' memory. So it can happen that few of the students is remembering exactly the correct word. So we will frame exactly the correct sentence from the other students, and then okay. If space, तो space जो है कार्पल टनल का वो फ्लेक्सर रेटिनाकुलम के beneath होता है. Okay, so if the space is there, okay, spaces. So either they have asked about pulp spaces, mid-palmar space. So you can just give me the hint via discussion, and we can know the exact words or the images. Okay. Singer cannot raise the voice post thyroidectomy. So basically, tensioning effect of vocal cord is done by which muscle? Cricothyroid. Cricothyroid muscle. And actually, the nerve supply of cricothyroid is by external laryngeal nerve. So cricothyroid muscle is getting innervation from external laryngeal nerve. Okay, spaces were given. Don't worry, I have already taken class of the spaces of the hand. Okay, spaces of the hand. So either cut section at the wrist is given, then carpal tunnel space must be there, or a section of the hand is given, then there will be many spaces, mid-palmar space, lumbrical canals will be there, the thenar space is there. Okay, so that way we can identify the nerve or the spaces. Okay, Mani. So basically, if I talk about laryngeal cavity, there is one nerve, that is superior laryngeal. Yes, external laryngeal nerve or superior laryngeal branch. So superior laryngeal nerve gives two branches, one is external and one is internal. Internal laryngeal is only giving sensation. Okay, pus collection. So yes, if the pus is collected, tightening effect of the vocal cord is gone. That means cricothyroid muscle is paralyzed and the nerve injury is external laryngeal nerve. Why external laryngeal nerve? External laryngeal nerve run close to which artery? Superior thyroid artery. So whenever an operation is done, We have to pay attention to recurrent and external laryngeal nerve. Recurrent laryngeal nerve will run along with inferior thyroid artery. We know superior thyroid artery will give blood supply through the apex of the thyroid gland. Inferior thyroid artery will give blood supply through the base of thyroid gland and the nerve running close to it. So when the thyroidectomy operation is done, we should pay attention while ligating superior thyroid artery to not injure external laryngeal nerve. if एक्सटर्नल लैरिंजियल नर्व की इंजरी हो गई तो क्या होगा, कौन सा मसल पैरालाइज्ड होगा, क्रिकोथायराइड एंड टेंशनिंग इफेक्ट इज गॉन. ओके ओके. Question number 16. This was a direct MCQ, maybe in the physiology pass. Okay, got it. Okay. Okay. Okay, got it, Dheeraj. मीडियन स्पेस ऐसा कुछ था. ओके, स्पेसेस ऑफ हैंड. ओके, स्पेसेस ऑफ हैंड से मैं को रिलेट करूंगी. ओके, डोंट वरी, स्पेसेस ऑफ हैंड. नाउ क्वेश्चन नंबर 16. व्हिच नर्व फाइबर कैरी प्रेशर सेंसेशन? अगर मैंने ऑलरेडी बोला है, नाउ आई हैव नॉट इन दिस पीपीटी आई हैव नॉट इंक्लूडेड दैट डायग्राम, लेकिन अगर सेक्शन है रिस्ट लेवल पे तो फ्लेक्सर रेटिनाकुलम के बीनीथ में जो स्पेस है वो कार्पल टनल स्पेस है. फ्लेक्सर रेटिनाकुलम के ऊपर में जो स्पेस है विच इज हैविंग वोलर कार्पल लिगामेंट pisiform bone and hook of hamate on either side, that is Guyon's canal. So either that can be the space or they must have given spaces inside, surgical spaces inside the hand, that will be pulp spaces and all. Okay, so which nerve is carrying pressure sensation? यहाँ पे जो right, it's a direct question, that is A beta fiber. So basically when I am talking about the large myelinated A beta fibers, they are very important for the stimuli. They respond to the stimuli like light touch, pressure and hair movement. Okay, so pressure. So the question was directly about nerve fibers for pressure sensation. So A beta fibers is the right answer. And if I talk about the other one, A delta fibers, it corresponds to the primarily sharp pain and temperature. Sharp pain and temperature. Okay. So I think this must also be has been explained in the physiology question. Now, one was the clinical question like this from the embryology. This was image-based question. Exactly, the arrow was marked close to neural tube. They have asked remnant of that structure. So, question mark is over this area. Question mark is over this structure, which is, this is NT, this is neural tube, and this is notochord. This is notochord. So, the remnant of notochord is nucleus pulposus. So, what will be the right answer? Nucleus pulposus. A beta is the right answer. Okay, that is also not right. A beta is the right answer. Mani, A beta. Here the right answer is nucleus pulposus. So actually this image is showing you the neuralization process, that is the formation of neural tube and central axis and how they form the, yes, nucleus pulposus, absolutely correct here. This was a direct MCQ. Image identify करना था. So many times आपने neuralization के images देखे and you are knowing that this is the neural tube and this is the notochord. So notochord का remnant होता है nucleus pulposus. That is the part of vertebral intervertebral disc middle part. Now this was another MCQ. This was the last MCQ. This was the last MCQ. What is the case below? What is this case below? What is this case below? So umbilical के पास एक छोटी सी herniation है and this is a case of umbilical hernia. This must be discussed in surgery MCQ and this is umbilical hernia. This is a case of umbilical hernia. So umbilical hernia can either occur in the adults or infants. Infants में reason क्या है? When umbilical ring, the opening of abdomen through which umbilical cord is passing, does not completely closes after the birth. It remains patent. It can lead to umbilical hernia. Otherwise, in adults, in cases of increased abdominal pressure, obesity, multiple pregnancy, also umbilical hernia can happen. Okay, my dear students, so I have discussed all the anatomy MCQs which I have gathered. Anything else which you think was more MCQs or anything else you want to ask, please message me or the team, Midway team. They will connect to me and I will certainly reply to it. All the best and be positive. Sure, the result is going to be positive because anatomy questions were very easy. कैसा आप रोहित, मानी, अभिषेक You find the anatomy questions very easy, no? So it's very good that you have got the most of the anatomy questions were easy, direct, and you have solved it. Okay, all the best. We'll meet in the next session. Thank you. So should I end? Okay, thank you. Okay, very good. Very good. There are many questions of anatomy must be integrated by surgery. So you just see ortho and surgery questions also. Thank you. Thank you.